Greetings from Seattle. This is Seattle on a typical day, as many of you know. That's the Fred Hutch here. It's a pleasure to be here. It's also a great pleasure because I stumbled upon my old friend, roommate, and chief resident, Jim Weedman, just a few minutes ago. We go back to the days when we treated CML with leeches. That's how old we are. They get rather fat when they're white cells and the like.
Before or after
So let's talk about CML and CML monitoring. Now, CML is obviously not a public health menace. It occurs about 2 in 100,000 people, but it's really told us as much as any other disease about really targeted therapy. And CML is unique because both the target of the therapy and the biomarker is the same thing, right? So it's pretty unique in hematology and oncology. So just to refresh everyone's course, the Philadelphia chromosome is from the reciprocal translocations of chromosome 9 and 22. You get a long 22, but the short 9, but the short 22 is the Philadelphia chromosome. And what that does on a molecular level, it puts the upstream domains of BCR from chromosome 22 to the downstream signaling tyrosine kinase domains of ABL. So normal ABL migrates from the cytoplasm to the nucleus. We're not quite sure what it does, but the new fusion protein BCR-ABL actually hangs out in the cytoplasm and causes an increase in proliferation that drives the disease. So targeting ABL is what we do with the tyrosine kinases, and then for molecular analysis, we can either look at cytogenetics by chromosome analysis, depending on how many metaphases you can get your cytogenetics to read, up to 20 or so, or the more sensitive test, which is looking at the chimeric mRNA, BCR-ABL, which has a sensitivity of detecting 1 CML cell down to about 10 to the 5th to a million cells. So tyrosine kinases have completely reshaped the landscape of this disease. And I'm going to talk about monitoring really in the context of outcomes because that's really the way it makes the most sense. So this is just a refresher of how good tyrosine kinases are and what the promise of molecular medicine is when you actually have a target. This is looking at the survival of chronic phase patients from eras. So this is when we didn't have anything, busulfan, hydroxyurea, interferon, and other things like era C. And this is the area of tyrosine kinases. So this has profoundly changed how we manage CML. So I'll give people over here a chance too. So we now have sort of an embarrassment of riches in CML. We've got 3 drugs that are basically a frontline therapy, imatinib, nilotinib, and dasatinib. We have many drugs approved in the second-line therapy, all those 3 plus bosutinib, ponatinib. There's amoxicillin, which goes back to Jim and my days as Homo Harrington, when it was a drug looking for a disease. It's still sort of now still trying to look for a disease. Allogeneic transplant, and there's various other things as really a 3rd or 4th line therapies. So we can measure disease response to patients in a variety of ways. It's just, complete hematologic remission, which really just means normalizations of white cell counts in the peripheral blood. That usually happens within 2 months. Cytogenetics, which is really what we're trying to look at, is complete cytogenetic remission. If you look at 20 metaphases, it doesn't count if you don't get up to 20. And then what we're really going to be looking at is molecular, and the 2 big things we look at here is major molecular response, which means a 3-log reduction in the BCR template from baseline, and complete molecular response, which you have to be careful, has a variety of definitions. This was originally just described as having negative BCR-ABL. Obviously, this depends on a couple of things. You can have complete molecular remission by either having a great response or by sending your PCR to a crummy lab. Those are different things. We'll talk about that later. So let's first talk about the results of the IRIS trial. So this has been was a spectacular trial. This stood for the International Randomized Trial of Interferon versus STI 571, which was what imatinib was called back then. But actually, it was reverse engineered. The chief administrator for Novartis in Basel was named Iris, so they basically designed the trial after her name. It was the comparison group was scheduled to was basically powered at expecting a complete response rate in the interferon arm of 25%. The study closed after a year because in the imatinib arm it was 70% after 1 year, and now it's gone out to 83% when you follow it over time. Event-free survival 81%. And the thing to remember is when we talk about major molecular response, in this trial, if you had a major molecular response, a 3-log reduction at 12 months, your transformation-free survival, that means not going into accelerated phase of blast crisis, was 100%. So we call MMR a kind of a safe harbor because when patients get in that deep of response, it's very unusual for anything bad to happen unless they quit taking the drug. And we'll talk about that a little bit later too. This is what the outcomes look like, which is absolutely spectacular compared to those old curves that I showed you. But if you looked at that trial, after about 5 years, only about 60% of patients were still on therapy. And you can basically divide the failures out in kind of tertiles. About 10% of people didn't respond initially. About 10% of people got off drug because they had toxicity, and about 10% became resistant. So there was some room for better drugs, and so the second generation tyrosine kinases came in. And for both nilotinib and dasatinib, it's really remarkable. There's been 3 randomized trials, 2 pharmaceutical, 1 intergroup in the US, pitting the second generation versus the first generation drug, and they all show essentially identical results, which is really quite remarkable. The results are basically, if you look at deep molecular response, you're better off with the second generation drugs than the first generation, so 80% versus 60%. If you look at the major thing we worry about, accelerated phase or blast crisis progression, 7% and about half of that in the second generation arm. But this is not yet translated into an overall survival difference, which is kind of curious, but so far, if you look at overall survival in these things, it's basically the same. The decision trial, same results, basically. MMR, 76 versus 64, accelerated phase transition less, survival, no change at all. So if you want to look at short-term effects that we think are important, getting a cytogenetic remission, getting a major molecular response, better with the second generation arms, better as far as transformation, but hasn't translated yet into a long-term overall survival difference. And that's obviously going to have a big impact in our healthcare system now that imatinib is coming out in its generic form. So when we talk about resistance, there's a few ways that we can think about resistance. As I'll talk about in a minute, 3-month point, if you don't achieve a complete hematologic response, which is pretty darn rare, or if you have Philadelphia chromosomes positive or BCR-ABL at greater than 10%. So most people, when they start, have a BCR-ABL by the international scale of somewhere between 50 to 100%. So if you have a log reduction or less by 3 months, that's a bad thing. At 6 months, you want to be at least below 10%. At 12 months, 1%. That 1% with BCR-ABL in the peripheral blood is essentially the same thing as when you become cytogenetically negative. And then at any time, loss of complete hematological response, loss of complete cytogenetic response, loss of an MMR, any development of mutations, or new chromosomal abnormalities. Now, for the most part, PCR has completely replaced cytogenetics. So both ELN and NCCN guidelines say you get a bone marrow at the beginning because you need to know if they have other chromosomal abnormalities because that would put people into accelerated phase bin rather than chronic phase. But after that, you can monitor people completely with a peripheral blood PCR. There's no need to do cytogenetics anymore unless you're masochistic and like to, or sadistic and like to do marrows on people. But there's really no reason to do it unless something wrong happens, meaning they fail therapy, they respond, then they relapse. Otherwise, peripheral blood PCR is all you need. Now, we've used 3-month intervals for PCR as sort of the standard of testing, and there is actually no biology to that at all. This was completely made up. And it was made up because before the tyrosine kinases came, the only place we did monitoring for BCR-ABL was in the transplant setting because that was the way that we treated CMLs then, right? In the old day, before imatinib, if the Hutch does 450 transplants, we did 150 for CML. That was how you cured CML. And for that indication, BCR-ABL testing was done, and it was done routinely around the world. We just made up the number of every 3 months. But it worked, right? So this is patients, when you look at their PCR value quantitatively, and this is their probability of relapsing after transplant. That's where all the data was first. And you can see that people who were negative after transplant had about a 2% risk of relapsing. If they had 1 copy, they had about a 20%. And if you had greater than 100 copies, you had a 40% chance. So that type of thinking went into designing the IRIS trial. And since the only experience we had was every 3-month testing, that's what we did. And that's what we did in the Decision trial and ENIS-ND trial and on forever. We do not know that that's the magic number. There's a lot of reasons it's kind of worked out well. Similarly, MMR. MMR was something that we just invented. This 3-log reduction, I can tell you exactly when it was invented. It was invented at 3 a.m. Pacific Standard Time on a teleconference between ourselves, Tim Hughes' lab in Adelaide, and John Goldman's lab in London. We were looking at the data about PCR testing, and we said, wow, look at this. If you look at a 1,000-fold difference, the survival curves fall apart. And we needed a name because we were going to publish it, so we said, we came up with MMR. We never expected it to stick. Other labs repeated it with archival data. It worked. But it was, that was just, God only knows, it worked. So that's what we're stuck with. So we're stuck with 3 months for testing for now. But again, this works. This is looking at the IRIS data, and we looked at 12-month landmark analysis. So you kind of ignore how people get here. You just take the survivors, which is the bad part about landmark analysis, and you say, well, what's your overall event-free survival based on your PCR level? And if you are at 1% or less, you're golden. That's one test in the peripheral blood. If you have more disease, you do worse, and you need to think about plan B. So at 12 months, it's got to be good. Can you go back? And long tail made short. We looked at 6 months, and we are now down to 3 months. And so you can actually start discriminating how people are going to do just based on their peripheral blood PCR at 3 months. This is data out of the Hammersmith, looking at this level of 10%. If you go below 10% by 3 months, that's your event-free survival. That's it if you do worse than that. Now, that's not rocket science. I mean, if your disease is starting to respond, you should do better than people who don't respond, right? So that makes some sense. But at a pretty early time, you can make a discrimination. This is data from the MD Anderson showing the same thing. This is looking at the cytogenetics, but this looks at the molecular data. Again, if you are greater than 10% at 3 months, that's your event-free survival versus better than that. So that's, I think, pretty interesting and convincing data. Now, this is just another example of why this is so potentially important. This is decision from the Decision trial, so dasatinib versus imatinib. The same exact data. I could show you the same slide for the ENIS-ND trial of nilotinib versus imatinib. You would see the exact same curves. It's really remarkable. So we said MMR is a good thing to have. So this is the probability of ever getting an MMR, cumulative incidence plot, versus what your BCR-ABL level is at 3 months. And it makes complete sense. If you have lousy response, your chance of ever getting an MMR is bad. If you have a great response, if you've already gone below 1% at 3 months, your chance of getting an MMR is great. It's exactly the same between dasatinib and imatinib. The only difference is what percentage of your population populate those spaces. So with dasatinib, you get more of these people who have faster response than here, and vice versa. But the shapes of the curve are absolutely what you would expect in a perfect world. It's one of those rare cases. So a number of places have recapitulated the Hammersmith data. This was the Hammersmith data I showed you, where if your PCR is bad, your survival is much different. The effects are a little bit more marginal, but all in the right direction. The only place is MD Anderson, where it's not really different statistically. So I guess if you have a PCR that high, you should go to Houston, live there. I don't know if it'd be worth it, actually. Now, part of this might be because in England at the time that they did this study, they didn't have any availability of dasatinib or nilotinib. So they couldn't rescue anyone when they switched. And so that might be why this group is artificially low. This is interesting data from Sue Branford in the Adelaide group. And so what they did is they looked at response by 3 months and 6 months, and then looked at various things: progression-free survival, failure-free survival, which means you didn't have to switch to another drug, MMR. And it's sort of as you'd expect. If you have a good response at 3 months, and then a great response thereafter, your MMR rate is spectacularly high, and it sort of kind of falls down as your response at 6 months is worse. But the worst groups are these ones. So for instance, if you have still greater than 10% at 3 months, and you wait and check it at 10 months, and it's still over that, your chance of ever getting an MMR is 3%. So kinetics matter, and that, of course, makes complete intuitive sense. So if you look at the patients who have EMR, there's a lot of data I'm not going to show here. If you add all that together, what happens? So 3-month failure, your risk of transformation to accelerated phase blast crisis is about 10% or higher. That, we're going to discuss why that is later. Your risk of death is 10%. Your risk of never getting to a low MMR, this means a 4.5 log reduction, which is sort of associated with being able to discontinue therapy, is over 90%. Now, the problem with any of these benchmarks is, we have a very rich history in oncology, especially hematology, of making rich continuous variables stupid dichotomous variables, right? I mean, look at MDS, right? It's MDS, it's 19%, it's 20%, it's AML, right? That's stupid. There's no biology to that at all, right? But we just invent these things. So the problem with the 10% thing, obviously, and you just have to start thinking as a doc, this is probably not the same as that. Right? If you have a person who's gone down, dropped, and they're just above 10%, they're probably going to be a lot better shape than someone who with therapy doesn't budge at all. Right? That's intuitive. And someone who is just above the 10% line is probably the same as someone who's just below the 10% line. Right? I mean, that stands to reason. So you have to kind of think when you go through this and not just look at cut variables. So testing at 3 months why is important. Assess response, right? There's 2 reasons that people can have a poor response. They're often hard to tease apart. One is that you have poor adherence, and we'll talk about that in a second. The second is poor biology, right? Those are 2 different things. You can consider changing therapy. The NCNN says consider it. The ELN says wait. But before you do that, think about what the patient's goals are, how the kinetics, what the slope looks like, what their adherence might be. When they don't respond, you have to think about progression and what it means. Progression usually comes early, and those people who don't respond well at 3 to 6 months might be people that you should at least start having talk to a transplanter and do HLA typing. So what the issue I want to go back to is here. So you'd think, okay, adherence, right? So this drug, I mean, I'm a transplanter, so the side effects for these tyrosine kinases are completely minimal compared to what we do to transplant patients, right? So, but CML patients usually are diagnosed when they're not sick, so anything you do to them makes them feel worse than they already are. But you would think, okay, you've got a pretty non-toxic drug, you take it once a day or with a line of twice a day. Doesn't, it's pretty easy to take orally, and it changes the whole natural history of the disease. You think, okay, adherence is going to be pretty darn good, right? So you would think so. So they did a trial where they basically had people in England raise their right hand and swear how often they took, their drug as prescribed. And basically 70% of people said, I faithfully take my drug without reservation, with never missing anything, right? So little did they know that they actually had an RFA chip in their cap, so they could actually tell exactly how often they opened the pills, and they could do some other sophisticated pill counts, so they could actually estimate how often people took their medicines. So we'll check the gauge the level of optimism in the audience. How many people think that they actually took over 66% of their prescribed dose? All right? Excellent. I have a bridge to this. 50%. 25%. Not 25%, right? 14%. So why does this make a difference? Well, obviously adherence is huge. And so this is Tim Hughes' head at a meeting. And I guess one way you could get adherence better if people just had to take one big pill. Actually, the reason I put it on is that the lawyers for this particular company said not actual size. In case you were confused that people were walking around with backpacks, gnawing on their nilotinib every day. But you have to convince people because this is what transplant is. That's a month's worth of transplant drugs, right? So you can pick your poison, literally and figuratively, right? So that's what we have to think. And when I see a patient with CML who is having trouble adhering to drugs, and you often wonder how much these side effects are real and how much are just they're not used to taking drugs, I march them kind of on their way in and out through the transplant clinic because I think they need to see what transplant patients, especially people with chronic GVHD, what that's like is the problem. But this is huge, right? Because this is your MMR and your CMR data on imatinib if you take 90% of your drug. So if you take 90% of your drug, your MMR rate's 90%. Your CMR rate's 40%, right? That rate in the imatinib trial was about 40%. So simply by taking your drug religiously, second-generation drugs may not be needed, right? If you just take your medicine as prescribed. So we say you have to monitor every 3 months. What implications is it? Well, this is two curves looking at relapse-free survival. This is patients who are followed and they get a half-log increase in sequential BCR-ABLs. This is your survival. That's if you have no rise. That's if you have a rise. So a rising level is not good. And this is if you lose MMR. If you don't lose MMR, you do really good. And if you lose, relatively bad. So monitoring has some consequence. And if you look at patients and say, well, when does a level matter? Obviously, if we say a log increase in your BCR-ABL is potentially bad, if you're negative and you go from negative to 0.00003, that's an infinite increase, right? That is way different than going from below MMR to above MMR. A tenfold when you have like a medium amount of disease is way different when you have barely measurable disease, and that makes sense. And this just looks at progression-free survival based on whether your disease goes up a log and crosses or doesn't cross MMR. Now that being said, I have yet to see, and we've done probably 10 to 20,000 PCRs, I haven't seen anyone whose disease has gone up to approach MMR and then suddenly taken a turn down without something happening, like not being on drug and taking drugs. The biology just doesn't work like that. The disease just doesn't change gears. So mutations. Mutations matter. This is these patients who are being followed at the Hammersmith, and they're being followed here sort of invisibly, and then they detect an ABL kinase mutation, which causes resistance in the binding of these drugs. This is their progression-free survival if you have a mutation, and if people don't have a mutation. And in looking at how people do, getting a mutation means more than anything else because it's a mechanism of resistance. Now, if you have a patient who doesn't respond and you do mutation analysis, you can take the results from that, and about half people will have ABL mutations, about the other half won't. If they have a mutation and all other things are equal, meaning they're not a pulmonary cripple and shouldn't get dasatinib, or they aren't an atherosclerotic cripple and shouldn't get nilotinib and the like, all things being equal, you can sometimes use these mutations to actually decide what drug you're on. There's all these heat maps around. Now you have to realize that these are completely contrived systems. What you do is you take a mouse cell line and you put in BCR-ABL in it, and then you put it in a dish and you throw these drugs on it, and you sort of get what the drug level is to inhibit about half the colonies. That's the IC50, the inhibitory concentration 50%. And then you take the same BCR-ABL constructs and you make mutants in it, and then put them in the mouse line and then grow, and you see if you need more drug or less drug and the like. So, and they work out pretty well. So you have, if you had a E255V mutation, you would say, well, imatinib, that's no good. But dasatinib's not bad, bosutinib's not bad, nilotinib you certainly don't want to get. So you can sort of use these kind of mutational things to kind of help you decide how you're going to go. These things do make a difference. This is looking at MD Anderson data. For any drug, they basically have pooled the imatinib patients, the dasatinib patients, and the nilotinib patients, and say, if they're resistant and you say they have no mutation, they have a low IC50, which means they should respond, or they have an intermediate or high IC50, which means that we wouldn't predict they respond, and this is their event-free survival, and you can see if they, for some reason, got this drug and you had an intermediate or high IC50, that's not good. For accelerated phase, it really doesn't matter. You're not going to go well no matter what, and you should get to transplant. This just shows that the concern that much of us have is that we think that probably resistance is forever. In that, we're all playing a Darwinian selection game in oncology, where it's kind of amazing that anyone ever is cured in any of these diseases. Because we now know that most of these diseases at the time of diagnosis have multiple clones. It's not just one clone anymore. Those clones, people always picture that what the fight that's going on you in cancer is your normal immune system versus the cancer. The fight is going on in the cancer as well. There are multiple clones. They don't like each other. right? And so what you do with therapy is you give a therapy, you select for the sensitive clone, and then the resistant clone grows out. By the time you have resistance with ABL mutations, you actually have multiple resistant mutations, and this is just a track of, with therapy, second-generation therapy, how some clones go away and some clones go back up, right? So typically, what we do is if we have a resistant patient, we will actually look at mutation status, change therapies, and then we'll probably start doing the unrelated donor search and the like, because some patients you'll cure with, or at least stop the progression with changing therapies, but many you won't. And this is the curve on this. This is looking at patients who are imatinib resistance, and you either give them dasatinib, nilotinib, or bosutinib, and you say, how often do they go back into a complete cytogenetic remission? And whereas at upfront, that's around 80% or so, basically 50 to 40%. So some of those patients will magically go back into a complete remission, but you shouldn't certainly count on that. Then the issue comes, well, how long should you treat them for? And so as it turns out, there's 2 studies that look like a window of about 3 months with a new drug is the best one. So this is looking at the Hammersmith data, and this says that they've got at least a minor response after induction of a new therapy. If you've had a response versus not, you can see the event-free survival and survival are very different. The MD Anderson looked at complete cytogenetic response after 3 months. If you change therapy for resistance and have a complete cytogenetic response, you're pretty good. If you don't, you need to think about plan B. So this works out just about right, because if you have a patient and they're resistant, you put them on 2-tyrosine kinase, and you start the unrelated donor search, the usual time to finding a donor is somewhere between 3 to 4 months. So you start the search, you start the new drug, they call you and say, we have a donor ready. The NDP hates this, by the way. The donor's ready. You go evaluate the patient, and you say, wow, they've got a great response. You say, fine, I'm just going to follow them. Versus if they don't have a great response, you say, that's enough of that, and you go to transplant. Because the thing you don't want to do is just keep watching them or waiting until they become resistant again, and then they get to accelerated phase of blast crisis, because then you move your survival with transplant from 85% in chronic phase to 40% in accelerated phase. So our standard monitoring, again, with diagnosis, we do it to other things. We do it 6 months until you get a complete cytogenetic remission. That's kind of old school, but what we'd really prefer you to do is just to replace it with PCR testing. And that's this testing, which we do 3 months, and then after you get a deeper response, you can really do every 3 to 6 months. And when to do mutational analysis, the ELN and the NCNN have different guidelines. I'm actually an honorary European. They actually just keep me there because they like to make fun of our healthcare system, so I'm kind of the butt of the jokes of these meetings. They have different words, but they're the same thing. Basically, if you don't reach a milestone, or if you reach a milestone and you lose that milestone, you get mutation testing. It's that simple. Now, the question then is when we make these guidelines, does anyone follow them? And the answer pretty much is no. So 3 surveys. Survey 1, 5,400 patients. This is the distribution of numbers of tests. Only 5% of patients had 4 tests. 60% had 1 or less test a year, right? You should get 4 tests a year. The region, no effect from gender. The effect is the West is best. Yay. East Coast is okay. Middle of the country, it's fly over, do no PCR testing. Survey 2, 40,000 assays. And so what we did here is we looked at if you had sequential tests and it was going up, and you would say, well, some of those patients should get mutation testing if you've kind of followed the rules. Not all of them, but some of them should. Less than 10% got mutation testing. Actually, 3% got mutation testing. So there. Survey 3, 100 community oncologists. All of them, 100% said, I believe the NCN guidelines are wonderful and they should be followed like the law of the land, right? Well, there's a little bit of disconnect between those 2 things. Right? There was another survey that looked at just within the first 12 months, and it's a little bit better. And that's probably because when people come in fresh, people are enthused, people test, and then they're doing well, and they just kind of forget about them. So that's a little bit discouraging. As someone who's spent a lot of time writing these guidelines. So here's your obligatory flow diagram. You're in first chronic phase, you get a tyrosine kinase. Milestones, yes, continue TKI. No, switch TKI. And then you get the response, yes, I'm doing well. No, you go to transplant. If you're in an accelerated phase, you get a TKI, then you get a transplant. Blast phase, chemotherapy, TKI, then a transplant. And I think that's it for my first talk.